The appointed hour is here. Niti, what are we focusing in on? What has everyone taken time out of their busy July to call in about today?
So today we have our panelists from Uganda and India who will be sharing with us some strategies, effective strategies on developing patient and community outreach programs. So moving on. We have simultaneous interpretation in Spanish for the entire duration of this webinar, for which we have Felipe and Eva joining us from Chile. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please click on that button and select Spanish. If you would like to continue in English, we recommend that you select English. This will enable you to hear the Spanish to English translation during the discussion if that comes up. If your bandwidth allows, please keep your video on. Use chat to tell us where you're from and who you are. Please display your full name on your Zoom screen if possible. During the presentation or discussion, feel free to type in your questions or comments or to use Zoom reactions. You will be muted during the presentation. If you would like to speak during the discussion, you can get our attention by using the raise hand feature within your Zoom reactions button on Zoom. Our agenda for today's hour-long webinar, we begin with a COCP update, followed by a presentation by Dr. Jayanth, Saudha and Sylvia for the first half hour. This will then be followed by questions and discussion for the remaining half hour. We have three core objectives at the COCP. Our aim is to facilitate networking and collaboration amongst cleft professionals, to communicate the impact and learning that's happening within cleft care, and to support the growth of local teams in implementing comprehensive care. We are a network of over 760 cleft professionals from over 80 countries spread across the globe. We would like to thank these 11 international charity organizations, all of who support the COCP and make these webinars and other events possible. Over to the moderator of this webinar, Hugh Brewster, to introduce our topic and presenters for today.
Thank you, Niti. Again, I'm Hugh Brewster here on behalf of the Circle of Cleft Professionals. Welcome. We're glad that you have joined us, whether it is the morning, the afternoon, or the evening. You are in the right place. And this is a topic, I think, that is at the core, very close to the core of every center that wants to develop in a comprehensive cleft care way. If most of the patients that you're treating live outside the city center, in rural places, or even a significant portion of them, how do they know about what services are offered at your center? And then how do you make sure that they can have a safe and effective treatment plan, even if they have to travel some distance to get to where a surgery can be successfully completed? So I'm delighted that we have three expert volunteers who have come to be able to share what they have learned and the strategies that they've put in place over many years with us this morning here in Toronto. That's Dr. Jayanth B.S. From India, who is a maxillofacial surgeon, and he leads the Bangalore ABMSS cleft team in India. ABMSS is one of the key sponsors of the Circle of Cleft Professionals, so we're delighted to have Dr. Jayanth with us. He also serves as ABMSS's medical supervisor. And today, I think he's calling in from Sri Lanka. So you'll see he's lovely outside. It looks like a great place to be today for this webinar. And then if we go a little bit further south and west in the globe, then we get to Saudha Nakandha and Sylvia Nafuna. They're both working at CoRSU Hospital in Uganda, which is a hospital that specializes in pediatrics. Saudha is a program and communication officer at the hospital, while Sylvia is a social work and community-based inclusive development team leader. And they also, within the Ugandan context, have had lots of experience in reaching out to families and communities about comprehensive cleft care services. So we are really delighted to be able to host this discussion today. We hope you'll keep track of good conversation topics or points along the way, feel free to use the chat. Otherwise, in about half an hour, we will circle back and spend a good amount of time thinking about what their insights, how they might apply to our own context, and also what are some of the concerns and challenges that exist around the topic of patient and community outreach strategies. So without further ado, I think Dr. Jayanth is going to kick us off from ordinarily from Bangalore in India, but today from Sri Lanka. Dr. Jayanth, please share with us a little bit about what you've learned.
Yeah.
Perfect. We see your screen.
Hi.
Technology is working.
Morning. Yeah. Good morning, good afternoon, good evening to all the participants out there. At the outset, I would like to thank TF for the invite and for making this talk possible. It's a very interesting topic to be talking as a team leader on how to get to outreach strategies to employ more patients who can be of help to propagate our own work. So I start off with can I?
Yeah, just click that from the beginning button. Yeah, I think that'll give us to a full screen.
Right. Yeah, I get it there. Are you able to see the screen there?
I think you need to go hit the from the beginning part. I think that's the
I'll do that.
Perfect.
Yeah.
Hey,
yes.
Perfect.
Okay. Yeah, this outlines my presentation. I would talk about us. That's the context in the southern part of India where I'm working. Then the reasons for why we need strategies and what strategies we employed in the past and where we are currently, the challenges that we face, and some recommendation along with ethical considerations for everybody to consider. I'm proud to be part of ABMSS, which stands for Akhila Bharatiya Mahila Seva Samaj, which is a pan-India non-governmental organization with a footprint across the country supporting 36 cleft centers and nearly about 4,000 plus surgeries each year. We are not into missions, but we believe in sustainable approach with permanent centers which caters to the patient's need as they grow with us. And we, apart from supporting surgeries, we also support 4 comprehensive care centers and 6 micro CCC where a part of the functional rehabilitation is done and not the full scope of it. And for this, we thank our partner Transforming Faces for guiding CCC across India through the partnership that we have established in the past 5 years. As you might all know, we are the most populous country in the world today. India is the most populous. We overtook China. So therefore, the collective exposure to cleft that we have is enormous. And Deutsche Kleftkinderhilfe, Transforming Faces, and Persistent Foundation are our key partners for cleft care services across the country. This is the hospital where I practice and I run my comprehensive care center. It's a 300-bedded hospital. We offer the entire circle of care starting from birth, consisting of nutrition, NAM, then the surgeries, then speech therapy, ENT, dentistry, orthodontics, a bit of psychiatric care, along with the outreach activities that we currently do. The aim of the organization and the center is to provide access to any child born with cleft for a safe and well-timed surgery and also comprehensive care treatment with a master treatment plan that can be implemented over a long period of time, over the long term, and to create such centers of excellences across the country. Now, getting to the core of the topic, why do we need strategies and what have we learned from this? Now, any cleft center would require patients to walk in for us to deliver the services. Now, without the patients, I would treat any patient as a god there, because without patients, we wouldn't be delivering any service. We will not be learning from our mistakes. We will not be doing good to the society. Therefore, the strategy is mainly to also address the success of the center, that we need a plan. And the strategies also help in maintaining the team strength. Uh, you have a beautiful center, but you don't have a sustainable patient input into the center, then your team members will also run away. And for the center to build up as a center of excellence, you need to have a strategy which is sustainable and low cost. So what we started off over the years is, initially when we started off, we would employ agents who would go around, work for us, and they would charge a bit for their running around and also for recruitment of cases. So this was the model that we followed over a period of many years, and we have given up that because it is driven by greed and desire. So this was in the earlier part of 90s and 2000s, during my journey earlier. And later on, we were going around meeting organizations like Rotary, Lions, and few other social organizations who would want to do some commendable work in the society, join hands and screen patients. Now, all this went well in the initial years of the organization, and we were getting good number of cases. But the drawdown with these organizations is, each year the team changes, and based on the passion that they bring into the work, you can either get plenty of cases or you might not get any cases. And for publicity, they end up doing a tokenism. As a tokenism, they would organize camps without patients. So again, tying up with other organizations was meaningless over a period of time. And finally, going around and organizing camps yourself, it is a thankless job and it tires you out. Doctors are meant to be in the hospital rendering service, but over a period of time, it gets to you, and you wouldn't be able to match your professional work with the outreach activities. So for that, what's changed over the years for us, and I've reasoned out why it's changed. Now, what changed for us is that we looked at who are the stakeholders for this. The stakeholders for this would be the government, because in majority of the countries, healthcare is driven by the government, and the onus is on the government to ensure health of the crowd there. So the stakeholders of the government, then the parents concerned here, who go from place to place seeking the best treatment possible. So we looked at the government, we looked at the parents, and we also looked at the cost to benefit ratio, and all the past failures, which summed up the new pathway that we had to take. And for this, we approached the government. We approached the RBSK, the health department. I'll tell you more about the RBSK, the health department, and the education department, because most of the kids today either are at home as infants and toddlers who wait for treatment, or they are in the schooling system. So the best possible way for us to get at them was to get to the stakeholder, that's the government there, through the health department and the education department, and also to reach out to the community through the Train the Trainers program, wherein we would target the healthcare workers, we were targeting teachers, we were targeting doctors, and also the in India we have a concept of Anganwadi workers who are in the primary school, who deal with pushing literacy mission for education and also deal with health of the primary school kids. So we had to involve most of them in our community outreach programs in the Train the Trainer program. And the picture on the right is about the camping that our Calcutta center still does. It's been a successful model. So the context in which we work also defines the pathway and the strategy that we adopt, and we evolve with it sometimes. So in my experience, the camping model has some limited role, but we have more or less given up on that, and we have gone ahead with the RBSK and the school model. Whereas Siddharth still has, he does a lot of outreach camps, and the miking is a way of trying to advertise publicly for the cleft and CCC services. And in a state like ours, Karnataka, the population is around 70 million. And each year, 1,800 kids are born with cleft. So if I need to reach out to such huge population, imagine the amount of expenses that would come by to involve advertisements or to reach out to the masses. So we have evolved into an economical program where we have tied up with the government, and most of the communication is passed down the line with the support of the government machinery. Now, coming down to the RBSK program, this is a health program launched by the Government of India under the National Rural Health Mission, where children from birth to 18 years with 4 Ds, that is the defects at birth, diseases, deficiencies, and developmental disorders and disabilities are picked up. And we have tied up for cleft lip and palate. Likewise, other organizations have tied up for congenital heart diseases, clubfoot, so on and so forth. So right at source, from the area of birth, the primary health center officer will call us up and notify us about the birth of such a child, and they'll pass on the message to the parents that they have to reach out to us. And from there, we guide them to the hospital and take over the management of the cases. This is regarding the primary cases. Now, coming to the educational department, it is the Sarva Shikshana Abhiyan. It's a flagship program of the Government of India to achieve universal elementary education. But they also have a policy within that to promote, wherein they promote education of children with special needs and differently abled children, and cleft lip and palate children qualify for this. And we have approached the state government with the intention to help them. And the minister and the officials involved were ready to welcome us. This is our 3rd year in the school program, because it's humongous. Nearly around 15,000 kids are there out there in the schools, and we have to reach out to them. And each month we target one district or one province, and do a Zoom meeting with the teachers, explain to them about the defect of disorder of cleft lip and palate, why the kids need more attention. It's a long drawn affair. The functional deficiencies that can come through beyond the lip and palate surgery, and what is the circle of care, and try to educate the teachers. And teachers being role models, when they carry the message to the next generation, the kids would always obey the teachers. So we have taken this route through the Sarva Shikshana Abhiyan program. And these are some of the photos of our outreach activities. So once we do the Zoom meeting with the teachers, I share my WhatsApp group. I create a group with that province and all the teachers, and they start listing out all the children in the cleft lip category, and they prepare a list for me in the next 4 weeks' time. And any teacher can reach out to me with any doubts. If a child requires a procedure, what would this child require, or is this a cleft, and how do we go about convincing their parents? I give them some tips. I sometimes talk to the parents through the teachers. It establishes and anchors us with the trust factor going through the teachers. And then we decide on a date, and we do a screening camp along with some comprehensive care, which can be delivered locally, mainly the speech therapy assessment and the dental assessment at the outreach camps. So we request the teachers to create awareness, identify such patients, and attend ensure attendance of the affected children with parents at the screening camp, and any old case operated at any different hospital is welcome to us. And you can see the annexure on the right side, wherein we have a referral format for the referral, because we then decide we also have a program where we reward the educational department of the district by appreciating them for the highest number of cleft children enrolled in the program, so that they are recognized for the social work that they do. So we get details about which school is referring the cleft child, from which province, what are the defect on the day of this camp or the outreach activity, and we share the contacts with both the parties. And a record is maintained with ABMSS and the education department. So that creates a sort of a registry we are creating a cleft registry for the entire province and the state, therefore. Now, these are some of the outreach programs where on the top left corner, you see that a lot of these cleft children have been, these are the nursing staff in a hospital. It's not just from the hospital, but the surrounding primary healthcare centers where the very basic healthcare workers known as the ASHA workers have come. They are the ones, foot soldiers, who go from house to house trying to identify all the 4Ds under the RBSK program. So they are the best people for advocating comprehensive care for us. And the other photos where I've been training the doctors. A lot of doctors themselves are not aware of the in-depth need for care in cleft lip and palate, especially the circle of care. And this is a camp involving the RBSK, where we have identified 16 patients at once, going through the procedure that I have explained earlier, some screenings being done. I just put up this photo to ensure that you can see the gentleman sitting there, the pediatrician of the province where I visited. I always go through the local doctor or the school teacher, because they are the first level of bridge between me and them, and the trust is very important to be established through them. So they are very important conduits for us. And again, training the doctors and the healthcare workers in a different province, and screening the mother, and the doctors and the teachers then start following up patients for us in the next months to follow before they end up in the hospital. And we give a report card back to them through the passports that we have, and send some messages when they don't come back to us. Another set of pictures where you're seeing that I'm trying to take them through the entire nuances of cleft. Both the parents and the kids are taken through that with the doctors being involved. And you have to keep the explanation of the care very lucid for them to grasp the entire circle of care. And in my experience, sitting and having discussions with parents and trying to clarify the role of each of the team members and what we are delivering would do no harm. And I've not come across camps where patients have not landed up with us after traveling 500 kilometers, 500 or 600 kilometers. They still come in spite of having surgical care centers around them. They still come. They value the advice being given in a mega camp like this, with the presence of so many doctors and like-minded kids are around us. Another set of photographs. So our outreach activities have reached out to primary healthcare centers, ASHA workers, who are the building blocks of the health system, Rotarians, Disability Commissioner's Office. Not everything has paid rich dividends, but these are the areas that we have concentrated our efforts on. Education department, the nursing staff, very important to sensitize them. A nurse will not know everything down in medicine. So you have to keep targeting them and keep talking to them. Every year I repeat the Zoom program. Some of them might get bored, but at least that memory remains in them. and I do get some referrals based on that. And the education department, the Anganwadi workers, traffic police, post office, postmans have reached out to a lot of them because they are the ones in the public. You sensitize somebody, you will be able to get one extra patient through the outreach activities that you do. Now,
and Dr. Jayanth, we don't want to cut short our time on Uganda. So if you could,
I'm going to wind up in 2 minutes.
all
just
right.
2 minutes.
It's
Now,
beautiful. We also need to put our focus a little further south into Uganda as well. Thanks so much.
Yeah, sure. Field coordinator, we select the experienced one. People who have worked in cleft centers have always been taken for the job. We train them in the centers to identify and advocate CCC, and they collaborate with me by directly visiting the houses of the cleft patients. And we sometimes have weekly and monthly troubleshooting Zoom sessions, or they come to the setup to discuss about the cases. The challenges that I face in this outreach activities are outreach is slightly expensive. The parents cannot be compensated for the travel and the food. In school programs, most of the school kids want to come at the same time to the hospital, burdening the setup. Taboos and superstitions also come as a hindrance for us when we deal with patients from outreach areas. Also, we end up with the ASHA workers and teachers who land up in the hospital for other health requirements. So we need to help them out. And we need to be flexible in these programs because exams might come in, harsh climate might change our schedules in the outreach activities. Some ethical considerations before I wind up. Parents coming from far off to bigger cities like Bangalore find it difficult to commute. They have to deal with loss of wages. We tell them upfront that we cannot take in their entire family when they come to the hospital. That puts them off, and sometimes the cultural and food barriers, because they come from different areas, can upset a few patients. So we also need to adapt and change to the culture. So these are some of the ethical considerations that we face, and I would just put up these 3 points for everybody to take home. Please consider the stakeholders in your strategy. Plan the strategy which is self-sustaining and that is economical. And finally, have an open mind for the community outreach activities. So I thank all of you, and I would await question and answers later on. Thank you, Hugh.
Thanks, Dr. Jayanth. Niti, where do we go from here? Oh, you're on mute, Niti.
Saying that we now go over to Uganda, and I'm going to be sharing that deck from my screen. Here you go.
Okay, my name is Saudha Nakandha. I'm Program and Communications here at CoRSU in Uganda. Here with me is my colleague Sylvia. And we are co-presenting this session. I'll take on the first bit of the presentation. We take a brief background about CoRSU. CoRSU is a comprehensive rehabilitation services in Uganda, and it is a non-profit government organization, non-government organization that was founded in 2026, and our mandate is to prevent disability and restore ability. CoRSU provides orthopedic, medical rehabilitation, and plastic and reconstructive surgery services. Among the reconstructive surgery services are the cleft lip and cleft palate repair or rehabilitation. Next slide. CoRSU works with Smile Train and Transforming Faces that enable us to rehabilitate the children and adults with cleft lip and palate. We move on to the CoRSU approach. The way we look at our activities, first of all, CoRSU has in place a comprehensive cleft care team that is headed by the head of plastic surgery and plastic and reconstructive surgery. That is Dr. George. If you know, I know many of you know him. That is our team leader. We make our plans, discuss them during the cleft team meetings, and therein they are approved. That is when we go ahead to implement them. So we cannot work alone. This means that we work as a team in everything that we do, including these activities, the social work, CBID, or awareness activities that enable us to reach out to our patients. We discuss every item that is surrounding the cleft lip and palate rehabilitation. Once it is agreed on, then we take it on. Our first strategy is we network with community mobilizers. First of all, the community mobilizers are people who are known. Their point of contacts in our communities, in the village settings. And we consider the community mobilizers as a structure that was established by the government. That is why before we consult or we take on any community mobilizer, we first go approach the local leaders, the government local leaders. So how we recruit the mobilizers is we reach out to the local government. The local government that is tasked with health issues is headed by the district health officer. The district health officer is the one who connects us to the village health team coordinator. The village health team coordinators are volunteers who are chosen by the district officials. They are entrusted to carry on programs that come on board during any time of the year. So because they already have an established network, we consider approaching government through the district health officer. So the VHT, the village health team coordinator, connects with the village team. They have another lower cadre team that they connect with. So when they connect with them, they coordinate and get back to us. Then we go on and train them. After training them, then they come through to CoRSU to sign a CoRSU mobilizers guide. We have a guide that we cannot work with anyone without putting in place a policy. A policy enables us to align our services, our works with people. You know, human beings can change. So we usually have them sign a CoRSU mobilizers guide. In that guide, we have the rules that they're supposed to follow, then their facilitation fee in there figured out, then the policies, the CoRSU policies, like the safeguarding policies. This is very important because they are moving around with children and caretakers who are vulnerable. They do not know places in the city. So they're moving with them through the city, villages, and everywhere. We make sure that they have to sign our policies and guidelines. So after they have signed the mobilizers guide, we make sure to give them an introduction letter. An introduction letter is is set in a way that it highlights the services that CoRSU offers, our location, and why we are working with the community mobilizers. We let the community know that we are working with this particular person in that letter. We put a disclaimer that this person is not, however, they are not CoRSU staff, but we are working with them on a volunteer basis. So in any case, even if they are to have issues, criminal issues in the communities, everything is highlighted in our introduction letter. Also, the copy that of the mobilizers guide that they took home when they were signing. So I'll let my colleague Sylvia take over.
Thank you, Saudha. Below, to add on where Saudha started from, below are some of our community photos when trying to train the village health team members in different districts. And to continue with the other strategies that we apply in reaching out the patients in different communities, we also go ahead and then sponsor our patients' transport to and from the villages. Most of the cleft care givers are totally vulnerable and their poverty levels are totally low, to the extent that they cannot even afford the transport to reach out to CoRSU for the cleft care treatment. So we go ahead and support them with the little transport. And with that, Saudha has already mentioned about the guide where we have the agreed on costs to do with the public means of transport. So these people come from different districts, but as CoRSU, we go as far as the main towns within those districts when it comes to offering them the transport. At least that enables most of them to add on little on top of that, and then they're able to reach CoRSU to receive the cleft care treatment. We also go ahead to build the capacity of the village health team members, and then also other community stakeholders. Among these stakeholders, we mentioned we have the district authorities, and then we have other community resource persons, then the village team members, and then the mobilizers. We train them on monthly basis in disability and basically in identification of cleft care, of cleft patients, and then the referral pathways. We also partner with the local health units. In communities, we have government health facilities, and we believe these are the focal points where all community members reach out for any health treatment. Mothers go to those facilities to deliver. So that's why we consider them so much, so that in case of any cleft child that is delivered, they are contact, and then they can be able to refer to CoRSU or link up with the social workers to ensure the patients reach CoRSU for treatment. We go ahead also to conduct the radio talk shows in these different districts, because the radio talk shows, we realize they cover a wide areas of the districts. They reach even down to the deeper villages. And we use that strategy to reach out to send the information about the comprehensive cleft care and then the benefits of the approach and the referral pathway, so that people are able to understand and then know where to come and receive the services. And then recently we started the follow-ups. With this, we go deeper to the homes of especially the cleft patients that have been worked on and those still under rehabilitation. Because we notice many of them, when they appear at CoRSU or at the hospital for the first visit, they tend not to come back. Some of them don't even adhere to the medical treatment. So we felt with the home visits reaching down with our outreach team, they are able to meet these caregivers, interact with them, emphasize these medical instructions, and then also explain to them the benefits of the comprehensive cleft care, and then the importance of adhering to the rehabilitation until the children recover fully. We also reach out to schools, because we have some of the cleft children that have been repaired already and are enrolled in schools. So we reach out to the teachers and then to other school staff talk to them about the challenges these children could still be experiencing. For example, the speech. Because we notice once they are repaired, the lip and the palate, their parents enroll them immediately in schools once they heal, though some of them need to continue with the speech and language therapy. So we notice some of the teachers do not understand why some of these children are still having challenges in speech. So we go ahead, talk to these teachers and then other pupils that are available to help promote inclusion, and then also be able to interact and be able to support these children that are still having speech challenges. Then another strategy is we disseminate our IEC materials that have cleft photos in different communities that we keep visiting, in even these schools, and then in other organizations in communities, for them to have a look at the before photos of cleft and then the ones after they've been rehabilitated. This only motivates them to continue with the rehabilitation, or even to know where to bring the cleft child in case identified at any point in the community. Native, okay. And then, of course, we've had some few challenges throughout all these strategies as we try to apply them in different communities. One of them is the high expectation, and this runs right from the community mobilizers. Saudha mentioned earlier that we facilitate them, but of course they come around with other expectations apart from the little facilitation that we are able to offer as CoRSU. Some of them expect to be paid for, like for their rent, others to be bought for motorcycles so that they are able to move around communities and then mobilize. So that has been a challenge on our side from both the mobilizers and then the caregivers. The caregivers, of course, at CoRSU we offer the comprehensive treatment, but many of them expect even the children to be paid for school fees in case they are enrolled in school. Some of them expect to be bought for food at home that they can keep feeding on with other siblings, which we are at times not able to offer. Then we have the lower commitment level. The village health teams, like we mentioned, this is a government structure that is in place to extend all health services closer to the communities. So you find they have different programs from different organizations that they are trying to support. So most of them, if at all their expectations are not addressed fully, their commitment tends to lower down. You'll realize at the beginning, you start with a bigger number that you train, but as time moves on, the number keeps on reducing because they're being engaged elsewhere, that they are facilitated fully or all their expectations are addressed fully. Then we have the political influence. We work with the government, like we mentioned, but we've had a challenge, of course, some of the government officials when it comes to political
they politicize
the program. Actually, they want to use the program to win vote from the community. And then it turns out into something else. So you find even the objectives of the program are turned into something political in a way that in case the other person fails politically, at times the program may not be also carried on or successful. So it's one of the things that we are still struggling with. However, this
Saudha and Sylvia, this is great. I just want to let you know we want to make sure we have time to talk. There's some great comments coming up. So if you could wrap it up really quickly, then we'll get a chance to hear from everybody on the call. I'm sure people want to ask more questions and discuss some of these points that you're raising.
Okay, thank you. So we are almost completing. So around those few challenges, of course, we have some mitigation measures that we are trying to apply to address some of them. For example, around the mobilizers guide, Saudha mentioned it has all the policies and then the the do's and the don'ts that binds us. So within those guides, the objectives are clearly streamlined, and that has helped us reduce on the expectations from the side of the mobilizers. Then other policies like safeguarding sexual harassment, those policies have also helped us reduce some of these risks that might be anticipated in their community. Then capacity building of the community resource persons has always motivated the mobilizers because they're equipped on monthly basis with new skills and knowledge in disability. Nettie, we move on. Saudha will take on with the recommendations and then the ethical.
From the CoRSU team, we recommend that intensified awareness can help bridge the information gap. This coupled with the follow-up and all the other outreach strategies we have mentioned earlier, will maximize the benefits of CCC. Then we will talk about the ethical considerations as we carry on our activities. One of them is respecting norms and beliefs. Uganda has a diversity of cultures, so you have to learn how people behave in order to fit in with your message that you're taking to them, whatever you're selling to them. Then we seek consent whenever we are reaching out to any communities. Then maintain political neutrality at all times. As CoRSU, in our activities, we do not get involved in any political sides. So that has helped us to build our outreach strategies. Then we observe all the CoRSU policies as we carry on our activities. Thank you so much for listening.
Thank you, Sylvia. Thank you, Saudha. And earlier, again, a huge thank you to Dr. Jayanth also. Great. Well, we have a little bit of time. There's been a large number of topics covered, and I think we'll take a second, just in your own context, what stood out for you? What are some of the things? I see a clapping hand from Dr. Felicity. Thank you. What is it that you'd like to hear more about? I posted a couple of questions along the way just for you to think about in your own context, but what is it about this idea of outreach and some of these local partnerships that stands out for you? And what are your questions that you'd like to hear more about from these experienced practitioners about what they're learning along the way in this very difficult and challenging topic? And again, feel free to post them on the chat, or you can put your hand up and ask them directly. Dr. Felicity, please kick us off.
I'll kick folk off. Firstly, congratulations, because without this kind of community work, kids who need care will never get it, irrespective of how fantastic the clinicians are who are willing and able to give care. And my question is, clearly both in Uganda and in Karnataka, it's taken time to get to this place. It's taken time to get buy-in, to achieve trust. Since we can't wave a magic wand and clone you and your setup instantly, what are the lessons you've learned that you would pass on to people to say, if you're going to repeat what we're doing, here are our top tips, here are the challenges we faced, what would they be?
Great, thanks, Felicity. And I'll just frame that a little bit. What's one top tip, just to start us off? And we'll start with Dr. Jayanth. You know, if you're thinking about the experience, and you helpfully, I think, painted a little bit of the history of, you know, exclusively on a just one-off partnership approach to now where you've come, what would you see was one key element that unlocked this ability to do some local partnerships better, Dr. Jayanth?
Thanks, Andrew and Dr. Felicity. The single point that stands out to me in the past many years of being there and having done this outreach is to tie up with the government. There's nothing that the government cannot deliver for you. They have the entire machinery available there for you to get the message down the line being passed on with regards to your comprehensive care, with regards to all the facilities that you have to offer. You
Thank you.
cannot expand that.
Great. So it's really spending the
the-
time on building those relationships locally, at least in the Karnataka context, has been super helpful for you in unlocking the next steps. Saudha and Sylvia, what would you say? Is there a contrasting learning that you've made about how to make local outreach processes work?
First, I'll say that when you're going to reach out to the patients in the field, outside the hospital, go with a neutral mind. Expect anything, no judgments, and be ready to deal with the situations.
Thank you. That idea of coming in, what your approach is. Are you coming just to let everyone know they're missing something and they need to come, or are you coming with that more of an open mind to learn? And I think you were clear about that, about saying that every context in Uganda is different, and coming in listening first is a helpful leading plot. That's great. Thank you. I've seen Erica and some other people, I think Patrick earlier had mentioned this again, focusing on this idea of volunteers. So it seems like you're expecting a lot of volunteers, both in the Indian context as well as in the Ugandan context. What is your recommendation or observation about how to make those volunteering relationships work?
Can we go first?
Please.
As already explained, we already, how do we make it work? We do not know the volunteers already, but they are known in the villages. They are known by the local government. The local government in this situation is the district health officer. So once the district health officer has entrusted us with this team, then we know for sure we are going to achieve at least 50%, not really 100%, because some of them usually drop out or have their issues that we cannot solve. So we rely on the grassroots government, the government itself.
Okay, thank you. So it's a good start. And then also recognizing you're not going to be able to hold on to all the volunteers. Volunteers have lots of things going on in their lives that can disrupt. So building your strategy, recognizing that there will be some attrition, that there will be some groups that will have to turn over, et cetera. That seems like a helpful starting point. Dr. Jayanth, what about you?
I briefly lost the audio there.
We're just talking about that idea of local volunteers. What's your connection to those people who have a real heart for mobilizing children facing this kind of challenge in their own villages or in their own communities?
Yeah, well, in the context that I have spoken, the volunteers in the education system or in the health system there, they have been super helpful. And you just need to reach out to them and make sure that you give them enough material on hand so that they can disseminate the information and be there to motivate them from time to time. There are enough volunteers available around us.
And Fernando on the chat has mentioned this idea of continual engagement. The idea of you can't sort of train volunteers once and then ignore them. This idea of continually reaching out and building relationships, making sure they feel recognized for their contributions, et cetera, being a key element. Right. Now, I think some people are also wondering about what about this idea of if volunteers have out-of-pocket expenses or transportation. How have you addressed that? That's a question that comes up everywhere.
Right. I did put this up as a challenge that we face. We try to compensate them where it is feasible, but it's not possible in most of the contexts, and we do offer them to reach out to us for any medical care in the hospital. So I could be of help guiding them in medical treatments for their family or their folks around, and that's how I can help them out. It's a sort of a barter system that needs to be considered there.
Interesting. Thank you. Saudha or Sylvia, what about how do you deal with these requests of sometimes volunteers being out of pocket or having to travel distances themselves to be able to assist with your outreach program?
Thank you. On our side, actually, the issue we mentioned was about the guideline. This is something we introduced right away from the time of identifying a mobilizer or a volunteer. And it has all our objectives very clear to them, what we are willing to offer to them or to facilitate, and what we shall not be able to facilitate to them. So this is a binding document that they sign. So most times, in case they want to go outside that, we try to remind them of the guide and the policy that they signed.
Right.
Yes.
So your approach then is that it is potential to have remuneration for some of that work, but it has to be within a very clear agreement that you can point to that is consistent. I think something definitely that can undercut any of these kinds of elements is this idea that there's some sort of corruption happening, or someone getting special treatment, or some people getting remunerated for some things and others not. I think that can really undercut that trust that has to happen between the hospital and going forward. So it sounds like you're really pushing for very clear guidelines that are reviewed regularly, and that that are transparently implemented for all the people involved in your program.
Mm-hmm.
Thank you. This is really interesting there. Ibrahim comments, what strikes me is the similarity between Africa and Asia and how beliefs can affect cleft intervention. There's a key area that our programs cannot ignore. Interesting. Thank you. Yeah, I think that they are two very different contexts, but I think we've seen some similarities there. Anyone else? What else would you like to hear more about? We have a few minutes left only. Anything that's burning for you in terms of this process? I mean, I think one thing we need to mention that definitely comes up, it wasn't in either of your presentations, but what happens if there are mobilizers working for different hospitals in the same region? So this sense of that there are folks who are connected to one hospital who are in a certain region, but there are also folks connected to another hospital, and then this idea of competition emerges. I mean, I know this is a longer topic, but we have to at least name this. How have you addressed this?
Okay. For us, we face that every day, every day, that for some VHTs, you send the money and they use it to refer to another facility. But we have a way of tracking. They'll still bring the patients. So if they take the patients the other side, well and good. The patient is getting a service from the other facility. So if they can get at other patients, it is the other thing that we consider, that a patient walks in, sees a nutritionist, a pediatrician, a social worker, they're able to see a surgeon on the same day, and are able to walk away with a nutrition package in case they need it. That is not anywhere in Uganda. That is the uniqueness that we have at CoRSU. So we don't really dictate what happens outside the hospital, but we concentrate on the quality of services that we offer at CoRSU that keeps bringing back the patients for rehabilitation.
Thank you. No, I think that's so really focusing on just clarity about what you offer, and then allowing if things happen and people go other places and they're getting good care, that's amazing. Felicity, one last point. We've got 30 seconds left.
Very quick, following on from that point, how do you deal with the risk of patients who have fragmented care, who hop from one center to another? Patients and families can't always identify what is the best care, but fragmented care can never be good across different centers and different protocols.
Great. We'll have to leave that question hanging, I think, Felicity, as a key one as we talk a little bit around this topic of competition. Thank you. I mean, we stick to our 1 hour. I think there's lots more to discuss. I hope, at least for you, as we think about your takeaway here, what is it that you'll take away? Is it something to do with volunteers? Is it how you're talking about your program? Is it something to do with how you're making connections to the local government? And is there further depth that could be achieved there? This is something you could talk about with your team. And if you found something really interesting in either from the Karnataka or the Ugandan example, this webinar will be posted on YouTube, and we encourage you to bring that back to your own team and think about, how could this topic itself spur some of these really difficult questions about how to move forward, but recognizing that many cleft patients live far from the centers in which you're most comfortable in doing surgery. So how do you move this forward? Anyway, we really appreciate your time. Thank you for joining us. Again, as Niti has put up, we have our YouTube channel. You can get in touch with Twitter, but also let us know if you have a topic or you have some feedback about this process, info@cleftcircle.org, and we'll get right back to you. A huge thank you to presenters. Thanks for everyone for joining us today, and we'll see you next time. Bye, everybody.
Bye, everyone. Thank you.
Bye-bye.
Fantastic presentations.